Good evening, everybody. Thank you so much for joining us tonight. My name is Heather Gocknauer, and I'm here with my co-host, Dr. Dawn Eichenfield from Rady's Children's Health in San Diego. We're really excited to have our HS expert panelists join us tonight. Tonight is one of our SPD virtual workshops where instead of our quarterly journal club, we do a session with a more clinical focus. So tonight we're going to use two articles as a platform to discuss HS. We're discussing the management of HS with dual biologic therapy, as well as some comorbidities associated with HS. We're really excited to have Doctors Cotton, Syed, and Davis join us. Dr. Davis is joining us from Mayo Clinic in Rochester, Minnesota. She's a professor of both dermatology and pediatrics and is chair of the Department of Dermatology there. She is an expert in inflammatory skin disease, including HS, and tonight we're discussing her recent 2025 article that was published in Pediatric Dermatology.
Thank you, Heather. And I have I'm very lucky I get to introduce our other two panelists. So Dr. Christopher Syed, he's a dermatologist and he's internationally recognized expert in HS. I feel like we can't say HS without saying Dr. Syed's name, and I hope I'm pronouncing it right. He's known for his leadership in clinical research, for development of evidence-based treatment guidelines, for advancing very comprehensive patient-centered care for individuals who live with HS. I'm very excited that he is one of our panelists tonight. And then also Dr. Colleen Cotton, who I've gotten the chance to work with multiple times. So she is now at Children's National and George Washington School of Medicine and Health Sciences. We're sad that she didn't want to come to Rady's, but we're and she has, of course, a great clinical expertise in HS. I think a lot of us in pediatric dermatology were all very wowed by her deroofing videos during the last SPD. She has a very strong commitment to advancing care for children with very complex skin disease, including HS, and she is a really impressive leader within our Pediatric Dermatology Research Alliance. So we're very happy that she is here as well. So I think we're going to get started with our first article. So I'm going to briefly touch on the first article, which is dual targeted therapy for HS. And this article is authored by some of our greats. And we see here Dr. Syed, and then I've gotten the chance to meet Dr. Shi and Dr. Sio as well. So these are some very great people who are a part of this article. So the idea behind this is if we can use one biologic for HS, why can't we use more than one? And it kind of makes sense because if we do transcriptomic and IHC analyses of HS skin, it shows activation of multiple inflammatory pathways. This includes TNF alpha, IL-1, IL-17, and JAK-STAT signaling. And then, of course, we also know about this with paradoxical signaling that when we suppress cytokine signaling in one domain, we have this theoretical shift that we often see where it kind of drives compensatory activation of other cytokine signaling. So it's like we're shunting the cytokines to somewhere else. So to date, I don't think I have any patients today who are on dual biologic therapy. I have lots of other things going on for my patients, but they published there's three published case reports in the literature. We'll review, I think, two of them in detail, and then one of them we'll kind of go over briefly, and then this will be like kind of the jumping off point for us to talk about these patients. And I don't think there's any pediatric patients yet published. So I think this is actually something that would be really exciting if you guys have patients who are on dual targeted therapy, we can probably kind of get these patients together and do a case series. I think that would probably allow us to really kind of get the information out there and allow patients to allow us to have more ammunition when we're trying to get these medications for our patients. So the first case is this 27-year-old female who has a 5-year history of early stage 3 HS. This developed during her first pregnancy. She has multiple abscesses, draining fistulas, and limited shoulder abduction because of it. She has also very severe pain and impaired DLQI. Initially, she was treated with isotretinoin and trimethoprim sulfa, and then this was switched to rifampin, and it was unsuccessful. Then she was started on secukinumab, 300 milligrams weekly for 1 month. There was minimal improvement. So then there was the addition of baricitinib, 4 milligrams daily. And then after 8 weeks of this dual combination therapy, 90% of the ulcers healed. The pain went down to a level of 3, the VAS score of 3, DLQI went to 6, and then she actually developed full arm abduction. And what's really exciting is that the laboratory parameters all remain normal and she had no AEs. So this is kind of a treatment success story. The second story is of a 25-year-old male. He had a 6-year history of HS, acne, and atopic dermatitis. He had previously been on infliximab, doxycycline, finasteride, and trimethoprim sulfa. He was switched from infliximab to adalimumab because of access and cost considerations. And then he was started first on the standard dosing that we usually do, which is 80 Q2 weeks. This was inadequate, so he was escalated to 80 milligrams weekly toward the end of 2022. And this led to partial improvement that lasted about 10 months. Then he developed recurrent painful draining flares. And then upadacitinib was actually added to the treatment regimen. He was also continued on his topicals, finasteride, and trimethoprim sulfa. Then after 2 months, his lesions had decreased in erythema size, drainage, and tenderness, and he had improved significantly, and his labs were also normal. In this article, they also speak of another pair of patients, Nayak et al., if you guys are interested in the looking it up. But it's basically the Hurley score was not reported, but they were also one patient was started on anakinra and certolizumab, and the other patient was adalimumab and anakinra, and both patients showed reductions in drainage, pain, and flare frequency and had no AEs reported. And what's really exciting about this article, I won't go into, I don't think we have time or to kind of go into it, but they actually list all the instances where dual targeted therapy has been utilized in other disease states. So there's actually a lot of literature, not in HS, but rather in like psoriasis and other disease states. So I think that that type of evidence is actually really useful for us because it shows efficacy in a different disease state. It also shows safety because I think sometimes when we're starting these patients on dual targeted therapy, we do worry about safety a lot. So now I would really like to invite all of our colleagues and the people from the audience can comment too, like all of our panelists, to have a discussion about these. These are kind of the questions that I really wanted to pick your brain about, and I'm sure that there's other questions as well. So the first question, so if I think our panelists can reveal their faces now. Okay, thank you. So my first question, I'm really curious from input from all of you guys, like what type of patient would you really consider putting it on a dual targeted therapy if you have patients on this? And what type of patient is not a good candidate for this? Do you think about certain demographics or certain other laboratory parameters that you might be worried about, ages of the patient, their access to your clinic, ability to get in?
I can wait for somebody to jump in, or I'm happy to jump in. Um, yeah, so I don't know that there's like many patients where I wouldn't consider it if we get to the point that like it's necessary. I mean, it's never sort of the first thing that we would do, or I think most of us at least. Like usually if I'm using dual therapies, it's because I've used like one, two, three monotherapies, like you often get in this trap where somebody's better on infliximab, but like they're not good enough by a long stretch. But the moment you take it away, they explode and things are much worse again. So you kind of get trapped where it's very hard to get them off of it. And if you just transition them to the next thing, they like explode before you ever have a chance to see if it works. And so sometimes we think of it as like a slight transition plan to do it for 3 to 6 months. Other times it's like, I know it's going to be a long-term thing. So that ends up being usually how we get there. And then like once we do that, like, there's nice case reports out there about it working very well, but for a lot of patients, it's just like monotherapies. Like you just have to hit on the right thing. And so you end up doing one, that combo isn't necessarily good enough. So you switch out one of those things for something else. And so a lot of these patients that we do it for are kind of like our most recalcitrant, worst of the worst patients. And so it's not like a super fair comparison against, monotherapy because we have this like rarefied group of patients who have terrible recalcitrant disease. And I may have them on, 3 or 4 different types of dual therapy over the course of a few years while we kind of land on the right dosing and the right combination. We have, we're sort of, I think we just submitted a case series of about 30 patients or so that are on various combinations of biologics and JAK inhibitors, mostly, TNFs, IL-17s, and JAKs. There may be some that are on IL-1s. Um, but yeah, it's basically like if a patient, has disease that is bad enough that they are not, and they're recalcitrant to monotherapies, at some point we're going to start stacking.
Do you find in your experience, since you have so many patients where you've done this for, do you find that immunosuppression, are you concerned about immunosuppression? Do you find that your patients are more susceptible to infections or take longer to kind of like to improve after they get like the flu or something like that?
Not really. I mean, we have such a long history of sort of using combination immunosuppression that in my mind is like much worse than like targeted therapies like TNF inhibitors and 17s. I mean, the idea that we do prednisone plus rituximab plus all this other stuff, like that is way more risky in my mind than a 17 and TNF inhibitor or 17 and 23, something like that. The one area where there has been clear increases in serious infections, I think there was one trial that tried to do IL-1 inhibition along with TNF inhibition, and they saw some a significant of an increased risk in serious infection that I think they withdrew that trial. But like, the best data from combinations is probably like the ulcerative colitis study where they did Simponi with ergolimumab and a TNF inhibitor along with guselkumab, the IL-23 antagonist, and like the safety looked just fine, like similar to what you'd expect with monotherapy. They had slightly better response rates on combination therapy than the monotherapy comparison arms. So that was a nice proof of concept. There's like an older, I think IL-17 TNF drug that AbbVie had at one point. They did for rheumatoid arthritis, and it just wasn't superior to adalimumab, so they didn't follow up on it, but it had good safety data also. And so, I think we had a few serious adverse events or sort of serious sort of things we report in this case series that we're working on. But a lot of those things were like the patients had terrible HS that still wasn't responding to combination therapy. And so they were sick in the hospital with HS, right? Like it wasn't usually other things where I was worried they were immunosuppressive. And they are like very sick patients that I think more have comorbidities and complications of HS rather than the medications causing those things. Because those weren't like opportunistic infections or things like that where I would feel like it's really tied to that. And those patients are also at high risk that if you don't treat them, that terrible things happen to them. And so it is a risk benefit sort of discussion every time. Like when I do that for patients, I say what we're doing is a little bit off the beaten path. Like this is not sort of what is standard and approved and sort of measured in 100 patients when it comes to safety and what's the right combination. But the alternative is your terrible HS keeps putting you in the hospital and you keep getting sick and can't get out of bed and can't keep a job. And so like it is time for us to probably do something more just like we've always done with off-label things. Um, I know some are a little bit hesitant about JAK TNF inhibitor combinations because I think there's just knee-jerk reactions around JAK inhibitors in general. I haven't seen that as a problem so far, and I like in general feel like JAK inhibitors have pretty good safety profiles actually, and we maybe sort of as a community overreacted a bit to data before we understood it super well, and it's been more reassuring over time. I think there's always a little more. I think the community in general has more hesitation about JAK inhibitor combos, but they're coming. I think people are developing dual JAK other inhibitors, and so we'll get more data on that with time. I'm talking too much. I'm going to be quiet.
No, this is great. This is great. Thank you so much, Dr. Davis.
Yeah, I would say that I kind of have a balanced approach or a mixed approach, and kind of leads into the second question about procedures. I find that where who I interact with and referrals that I get, that if you ask a surgeon, they'll say that HS is purely a surgical disease. And if you ask more of a med derm or a peds derm, they'll say it's a medical disease. And I kind of think of it as a combination thereof. And I have some patients that have very refractory disease, but it's geometrically or geographically very limited on their skin. And I would much rather have somebody see a Mohs surgeon or plastic surgeon and have the axillary vaults or the inframammary areas excised if that keeps them from being on dual, targeted therapy for an indefinite amount of time, if nothing else, just due to convenience and cost, insurance battles, and risk. For patients that have more diffuse disease, I would consider stacked therapy after I've exhausted everything else, but I try to use what I call lower risk drugs or drugs that I think are more common to use. Like I try to optimize spironolactone. If they're females, I try to put everybody on metformin. I try to make sure that all of their other systemic diseases are under good control, and then lifestyle modification. But yes, I do think that there are some patients that have very diffuse severe disease where they need drug stacking. And I think anakinra is low risk. I think it either works or it doesn't, and you can see that quite early. And I think the side effect profile is quite benign, and it doesn't have the lure or legend of JAK inhibitors, or the concern of do we do quote rheumatology doses of JAK inhibitors, or do we do quote unquote dermatology doses of JAK inhibitors?
I'll chime in. I don't have anybody currently on dual therapy. I think a lot of times if I have somebody who has failed one or two monotherapies, and I think this is the thing that's a little unique about pediatrics, like I do try to take a step back before I throw something else, a different part of the immune system on top of it and send them to immunology just to make sure that there's nothing, unusual that I'm missing in their, in their history or something in the way that their immune system is functioning. It's rare, but there are cases of female carriers of chronic granulomatous disease, X-linked, that shows up like later in life, and that can definitely mimic a lot of the findings that we see in HS, IBD, chromo, things like that. So I do typically send them before I would consider somebody for dual therapy. And I also, to the surgery question, like I've definitely really tried to drill in with patients when they say they're not responding to a treatment. Like if I look at them and I think they don't look any better and I think everything is terrible, we're going to move on. But I always do that exam, even if they tell me they're like, I'm exactly the same. Nothing has changed. And I like to take photos because it helps me figure out if there's just tunnels that are not responding to the therapy, but they're no longer getting new inflammatory lesions. And so that tells me, I'm like, well, why don't we do surgery first before we try adding something or switching something? Are they still getting new inflammatory lesions? Or they're like, well, I don't have pain anymore, but it's still draining. So I also try to kind of drill down with patients when they say they're not responding, because I think I've gotten burned before with switching therapies because I didn't feel like we were good enough. And knowing what I know now, I switched them and they exploded. Um, like Chris was saying. So, you know, I it's hard to get those people back under control once they, flare off a therapy that was like kind of working for them. It's not like you can just go back and do it very easily.
Yeah, I totally agree with that. Like there are definitely times, like you said, where the most important question or thing you try to sort out when somebody's on a therapy is like, how much are you getting that's really new or where the tunnel barriers are spreading, and how much is it just the same old stubborn areas that just are having trouble completely healing? Like, with medicine, you should expect less pain, less drainage, like hopefully less or nothing in the way of new lesions popping up. But I show them in the mirror at the first visit, what their armpit looks like, and I think this is where it tunnels and connects. And you probably know that this spot has not just been here for a few months, it's probably been there for many months or years. And we're going to calm it down and make it less intense, but probably at some point you'll need surgery to be the best you can be on top of the medications we use to stabilize things. And yeah, if that's all they have is like a few areas that have been a little bit recalcitrant, and we can sort of nudge towards a surgical approach, either clinic-based things or referring to partners to do sort of bigger stuff, then yeah, at that point, it's like you can only escalate so far and get so much out of medications. So setting that expectation ends up being key and figuring out, when is it the right time to have procedures versus they are really unstable or they have so much surgical burden, it's going to take a really long time, like 2 years of aggressive stepwise surgery to get them well. Like, yeah, maybe you keep pushing just to get them better in the short term.
I guess when it comes to procedures, when do you opt for like a full excision versus a deroofing surgery?
I think for me, part of it depends on because I'm the person who does the de-roofing, so it depends on if I'm scared of the amount of an area that's involved, and I'm like, I don't want to get in with that whole thing. I think often I start to think about just sending them for surgery either when they have like very diffuse ulcerated disease. I feel like that's very difficult to for me unless they get under control with a therapy. I feel like that's really hard. De-roofings are tough to do in a situation where it's just a bunch of open ulcers. Um, but I also like if it like in the axilla, for example, if it crosses that line, if it crosses that area where it's like this is upper arm and this is like trunk, if it crosses that, then I start to worry that they have like more significant kind of deeper tunneling that might benefit from a wider excision. But I'm curious what you guys think, especially since Chris taught me de-roofing via Zoom during COVID, so he's definitely a person I would defer to.
Yeah, it varies some like excision versus de-roofing. Like, I'm not terribly convinced that one is like way worse than the other when it comes to like recurrences and things like that. Like, I mean, and to some extent, if you do, yes, a very large excision of the entire axillary vault, you're a little bit less likely to have recurrences in the long run, probably, just because you've cut out more skin that's going to be predisposed. But it's also a much more morbid procedure most of the time than doing something relatively localized to where the tunneling is. So usually I'd start with something that's more focal, at the area. If I think the disease is stable, something more focal, don't put them through the bigger surgery if you don't have to. And then if they've had one or two recurrences and they're like, look, I just want to do something big and sort of limit the risk of something coming back, then yeah, potentially you do an excision instead. Or if a patient just really strongly prefers a sutured wound, you need to do it, you need to excise as opposed to deroof to sort of do a repair. And so in those situations, they're better off, with you excising more deeply. But I mean, 90 to 95% what I do ends up being deroofings at this point, even when it's very extensive, just because you end up leaving intact, a lot more intact dermis. There can be portions that go into the subcutaneous fat for some patients, but you leave a lot of intact dermis. And so there's a lot more pliability usually, like less risk of a scar being really tight and contracted. Um, you're less likely to affect like in the axilla, like the intercostal nerve if you're deroofing, because that's kind of mid-fat. And if you excise, you're more likely to hit that. And then patients have like dysesthesia or sort of hypersensitivity over the front of the shoulder, the upper arm. And then I think the deroofed wounds heal a little bit faster, on average. That's not always the case. Even the deeper wounds can heal pretty quick sometimes. But even places like buttocks, groin area, labia, like deroofing in those areas, I think particularly on the buttocks and perianal area is long term much better for patients because if they get a really huge excision on the buttocks, like down to the fat, their scar contracts and they've got full thickness scar and they feel like they're sitting on a piece of like hard wood all the time just because it's so firm to sit on. Whereas for a lot of cases of de-roofing, even when they're extensive, you got a fair bit of dermis and it's much more pliable and soft, and so they have a lot more cushion afterwards. So they're not like always sitting off on kind of half their butt, when they come into the office. Because the healing, I think, there is a little bit better too. So again, you can do very extensive de-roofing, just like you can do very extensive excision. Part of it is probably, I think outcomes can be good either way. So I think it's whatever you train with and feel comfortable with is fine when it comes down to it. It's not hugely different, but my preference generally is de-roofing because even if I do an excision, I'm sort of partway doing the de-roofing because I want to delineate where all the tunnels are and make sure I haven't sort of stopped short for my excision, that I'm also not cutting out things I don't need to cut out. And so usually it's like I kind of explore and do that part and then would cut out the circle kind of around that if I was to do a deeper excision.
I would say I'm probably a little bit more aggressive. I agree with Chris entirely that the genitalia and the buttocks are the two very refractory areas where consecutive de-roofing, I think, is just a practicality. And I tell patients that I kind of give them the three strikes, the skin is out kind of rule, where if I have to tunnel the same place or de-roof the same place three times, I worry that after 3 rounds of scarring and de-roofing that the skin is just so damaged that I'm not sure it will ever heal well, even if they're on a good medical regimen. And then I recommend excision. And I do really look at patterns on the skin. A lot of people have HS that's everywhere, but some people just magically have horrible HS, but somehow it stays in one geographic location. And with the exception of the genitalia proper, the inguinal folds, are fairly straightforward. The sternal crease is straightforward, inframammary areas as well, in the axillary vaults. And so I think those places are fairly easy to excise with help of a good plastic surgeon.
Going
We
back.
got a question. Oh, go
Oh,
ahead.
I'm sorry, Dawn, go ahead.
I was going to say we got a question from the audience about getting coverage for dual biologics JAK therapy. Any tips about that? And then there was also a comment about adding on roflumilast. If anyone's done that.
Short story is like it's annoying because you're fighting the insurance, and so it's not always a guaranteed thing. Like if people happen to have two diagnoses that you can sort of use one versus the other, like if you've given them Bimzelx and they get one of the rashes you get with it that looks a lot like eczema, like then you can maybe get a JAK inhibitor covered for their eczema and say they need one for one thing and one the other. Or if they've got some arthritis, kind of same deal. You can try to rely on two diagnoses. They still fight you on that sometimes. If they've been on every approved FDA indication, you write the standard appeal letter that says there are no more FDA approved options. This patient has exceptionally bad disease and they have pain and bleeding and suffering and physical disability, and try to use buzzwords and highlight those things of why it's an unusual case and you need an exception. That's what they want to hear usually. And then we do a lot of relying on free drug programs. Like there are some companies who, even with off-label use, will provide those drugs to patients. If you sort of have done the regular authorization, you do the appeal and that fails, you can attach the denial appeal letter to it and just write in the margin of their insurance, like insurance is refusing to cover on appeal. And a lot of those companies will provide free drug in that instance if they meet criteria otherwise. That I'm actually sort of like very worried for some of these patients because Johnson and Johnson that has, Remicade, they have Tremfya, though I don't use that all that often, and they have Symphony, which is another sort of backup TNF inhibitor, is sort of handicap, like they're cutting back on their free drug programs because of biosimilars coming along for those. So new patients that aren't in the programs now can't apply. So getting free Remicade for patients in those circumstances is gonna be much more difficult this year. And I've been like trying to argue with them and like maybe starting some advocacy around that because we're gonna have a lot of patients who struggle. They're saying same for like Stelara is another one that maybe I mentioned Stelara already. Tremfya they still have a good program for. Stelara because of biosimilars they're not going to do anymore. So that's going to cut off some, but like AbbVie has a very generous program still. So like Rinvoq, Humira, even though Humira's got biosimilars, they're still supporting it really strongly. So if you need to escalate your dose and they're denying that, or you're getting insurance and you can't do two at the same time, again, you can get it that way. So there's some tricks to it. And the HS Foundation has a lot of appeal letter templates on their website, but I don't know how many are like sort of are specific to dual therapy. But again, it's if you're not doing it often, it's not too hard to write the occasional appeal letter for it.
There is a specifically like dual therapy letter on the HS Foundation template that has been put together, which summarizes a lot of the literature that's actually in this article that you can use to make an argument for it. I do think if you're trying the two things that I've done that have been helpful, well, three things. One, if they have a comorbidity, like Chris was saying, if they have eczema, if you start them on a TNF and they get paradoxical psoriasis, oh gosh, look, they have psoriasis now. If they have Crohn's, if you think they might have Crohn's, I send people to get evaluated for that because it's so much easier to get any kind of drug if they have Crohn's disease. Um, Even if you're not 100% sure if it looks like cutaneous Crohn's, I've had some GIs be okay with me calling it that. So that's one thing, is make sure there's not another comorbidity. Number two is if you can get away with infliximab as one of your two. Number one, it's a biosimilar, so it's cheaper. So all insurances are going to prefer that over most other biologics. But number two, depending on how that insurance prefers to have it covered, that may be covered by an entirely separate part of their medical benefit that does not necessarily talk to the part of their medical benefit that does, like biologics that come from a specialty pharmacy. That's not always the case, but you can kind of get away with it in that scenario as well. So if you can have a biosimilar, or particularly infliximab, even if you can't have infliximab, if you can have a biosimilar as one of those drugs, then you can make an argument that, it's significantly less expensive for the insurance company. I've also, when I'm not using a JAK as something, because I haven't done dual therapy for just HS, but I have some people who are on dual therapy for like other things plus HS. So I think if JAK's not going to be one of those, you can make the argument that JAK has a worse safety profile than the things that you're trying to combine for them. And so it's a better thing for them to do these two biologics than to switch to a JAK inhibitor, which would be their next option.
I
Thank you.
think some aspect from the last, like that has sort of been making the rounds a lot, and it's pretty good for psoriasis. I don't know that it's like super helpful, particularly in these like really recalcitrant patients that we're doing dual therapies for. It'd be fine to add it on, and there might be a subset who do okay. I've been like a little more likely to use it in patients who are needle phobic and they've got kind of milder level disease to sort of try to, get them on something that's going to be more anti-inflammatory. I just like a Premolast. There's a lot of GI upset, maybe even worse than a Premolast, and so it is a challenge there. But it's a nice thing to think about. And again, probably more useful for psoriasis ultimately. It's like $20 a month, I think, through the Mark Cuban pharmacy is probably the cheapest way to get it right now. So it is like very accessible as a nice thing. Because even though it's generic, some insurance will still reject it. So it's still accessible kind of with cash pay through something like that.
And you mean like oral roflumilast or topical? You're talking about
Oh,
oral,
that's
right?
what we're from the last.
Yeah.
Sorry.
Okay, that's what I
Yeah.
thought.
Yeah.
That's what I thought.
Yeah, topical would be like $800
Yeah.
a month, I'm sure. So
Thank you so much, everyone. Let's just for the sake of time, move to the next article here. Okay, so this is an article that Dr. Dan Davis was a senior author on late last year. So in this article, they're looking at obesity, and we know that obesity is linked to increased HS severity and various comorbidities in adults, but this article really explored some of those associations in our pediatric population. So this was a retrospective cohort analysis that looked at about 180 pediatric patients with HS, and they had about 900 matched controls. And so they compared trends between HS patients with and without obesity, and then with the healthy controls for comorbidity development. And so some of the findings I will just review really briefly, but we didn't see a difference, or they did not see a difference in Hurley staging between the patients with and without obesity. And I think we could, talk a little bit about, maybe some of the limitations of Hurley staging in kind of diagnosing the severity of HS. And they also saw that patients with obesity were more likely to be prescribed a biologic than patients without obesity, but not other treatments. And then they also reviewed that patients with HS had a higher prevalence of all shown comorbidities. And I think this is something that a lot of us are familiar with from our clinical experience, that a lot of these kiddos and adult patients do that come in with HS have a lot of other things going on as well. And then they controlled for obesity or controlled for BMI and saw that patients with HS had an increased risk for these following comorbidities, even after controlling for that. So the odds of developing these things were decreased, but not completely eliminated. And so, does this kind of offer evidence for the idea of screening for these comorbidities in kids with HS, even regardless of their weight? And so I know I went through that super briefly, but I want to allow enough time for us to kind of chat about it. So just kind of some talking points that I started with are, where we talk a lot about these comorbidities in these kiddos, and, are they coming into your office and are you ordering kind of all these labs like a lipid panel, or are you taking their blood pressure every time, or, doing a depression screening or thyroid studies? Are you doing those kind of things? Are you alerting the PCP to do them? I guess we can kind of start there, and I'll open it to Dr. Davis first if you want to chime in.
Yes, absolutely. So when patients come to my clinic, even if they're a local patient where their primary care physician is at Mayo Clinic, I order all the screening metabolic labs myself. And what I tell patients is just like eczema and just like psoriasis, we used to think that HS and these other diseases were simply skin diseases. And we now know that they're systemic pro inflammatory metabolic disorders, is the way that I think of them. And they just happen to manifest more commonly on the skin, but that we probably don't appreciate what's going on systemically. And sometimes I do find things that are occult and the patient didn't know that they had. And then that's very helpful. And I always say that if you have something else we find, we need to manage that before your HS will have a chance of being under good control. So, with regards to weight loss, I recommend a healthy weight. And I kind of state it as we just want you to maintain a healthy weight. And based on the age of the patient and their mental health state and the aura of the dynamics of the family and the patient in the room, a lot of times I'm very sensitive to be sure that we don't give a child or a family an impression where there would be some sort of eating disorder or body dysmorphism. And so a lot of times you can just keep the weight steady and allow a patient to grow into their weight as they age, which I think is helpful. And we talk about lifestyle modification factors that can help a lot with friction and things that help hopefully prevent or at least prevent progression or flaring of local disease. And then with regards to metformin, I love metformin. I think it's great. I prescribe it for patients across the BMI spectrum. And I usually start with 500 milligrams. I always suggest they take it with food and then increase slowly if I need to, based on effect, up to, 1,000 or 1,500 milligrams. So I would just be curious what Colleen and Chris say.
So I'm like you. If they come to see me, I'm getting those labs myself unless they have had those specific ones that I want done with their PCP, which they usually haven't done all of them that I want. Plus, for a lot of these kids, especially with more severe HS, they're seeing us way more often than they're seeing their PCP. They may not even have a PCP. So I think that it makes sense if you can get comfortable with it. I get to cheat a little bit since I have adolescent medicine in my multidisciplinary clinic, but there's lots of kids that I see that I don't see in the multidisciplinary clinic. So I typically will check like a hemoglobin A1C, but I also want a fasting lipid panel and a fasting insulin level because I find a lot of insulin resistance, even in people with a completely normal hemoglobin A1C. And I think being able to show someone a number that says this is the number that says you might benefit from metformin or whatever treatment is helpful for people if the number you're pointing to is not your weight. So I like having the insulin level. I do check a vitamin D since a lot of my patients, they might be a little low, but the ones that are very, very low, I do think that it helps to kind of bring that up. And anecdotally, I've had some patients who feel that that's helpful. Um, and so those are kind of the big things. If they have irregular menses or if they have like very, very heavy periods, I'll also do a PCOS workup in those patients. The PCOS workup includes the thyroid screening. I'd be curious because I didn't see it in the paper, but I was wondering if the thyroid increased risk was compared to the number of patients with Down syndrome in the population. Because I know in a lot of my Down syndrome kids, a lot of them have hypothyroidism. And so they're already on Synthroid when they come to see me. And so I want to make sure that that's in line and balanced because if that gets off, that can also affect their HS.
Yeah, I agree. That would be considered a confounder. So I agree. And I'm very proactive with sending all females, regardless of whether they're thin or they think their menses are normal, to have PCOS screening as well.
And Dr. Davis, you'll send them to endocrine, or will you do some of those screening labs yourself first?
I do all the labs myself.
Okay. Okay. Dr. Syed, did you have anything kind of to add to that piece?
Yeah, I mean, I think it's all, I think I'm less diligent probably. I see more adults than kids by a long shot, so I'm like skewed in a little bit of a different direction. I mean, the adults have just as bad or worse comorbidities, but most of the time, we'll bring it up and they've got a primary care doc who's hopefully managing those things, or if they don't, I'll mention at some point that, these are things that should be evaluated. But I'm not usually good about at least every kid who comes in the door, like saying, let's go do this initial lab panel workup. I mean, there are relatively significant rates in that series. I mean, hypertension was about 3%, and then dyslipidemia was like the odds ratio is increased. I guess it's about 7 or 8%. So, I mean, you pick up a fair number by screening that way. And at some point, we did like broad A1C screening for everybody that walked through the door, and like about 20% had known diabetes before we ever screened them, and so we didn't screen them at all. And then there were 20% that had like either pre-diabetes and just a few that had diabetes that wasn't diagnosed at all. So yeah, if you do it enough, you do pick it up. And if I do like blood work to start a biologic or things like that, I'll often add an A1C. But I'm probably not as good as I could be about like doing a lot of this other screening myself. The thyroid is kind of a surprise. And yeah, I wonder, yeah, maybe there's a group of Downs patients in here that's triggering that some, but even with that, like that's pretty significant to be at 11%, and it's 20%, like 20 patients out of a large cohort. So that's like pretty, seems pretty substantial. So I'm gonna have to think about maybe screening or talking about that more often with folks. Um, I use metformin some. Like I don't find it to be. It is probably like a little more helpful in this group that's going to have like be earlier in their disease potentially, but like it is hard to tolerate sometimes with diarrhea for about a third of patients, and I'm never like overwhelmed with response in patients that have bad disease that are kind of on the worst end of the spectrum, which I see like probably I'm skewed towards worse disease on average than most. And so I just have never been like, it's like if I'm going to start something, there's often other things I would think about first. Or I feel like, spironolactone OCPs for females probably do a little bit better than metformin on average, but it can certainly be stacked on and is sometimes helpful. And weight is like a sticky subject. I mean, the striking thing to me in this is that like, two-thirds of patients in this population like were not obese, right? Like most kids who develop HS were not obese, and if you develop HS, like you have, you're going to be socially isolated, you're going to have depression, anxiety, you got 10% almost to have PCOS. You have all these risk factors that contribute to obesity for this subset of kids as they get older. And so the idea that it's, causative for most people that like they become obese, they develop HS, I think is undermined by like, these kind of cohorts where most are actually not. And maybe it increases risk slightly, but I think it is a two-way street. Like maybe there is some predisposition with obesity, but if you have HS, it is much harder to exercise. Like, again, the comorbidities that go with that, like, are going to lead to a higher rate of weight gain. And even things like TNF inhibitors, like, probably are associated with weight gain for some patients. So the things we do to patients sometimes, like, maybe also make it harder for them to lose weight. Um, Somebody's going to ask questions about GLP-1s, I'm sure, but I'll wait. I'll wait to be prompted.
Yeah, I appreciate you bringing up the thing about obesity. And what I tell patients, no matter what their BMI is, and I think it's also like I tell patients, there's nothing you did to cause this. It's not your fault. I think that's important for parents and the patient to hear. And it's also nothing the parents could have done to prevent this. I talk about how there's a big adage or layperson's myth that obesity leads to a lot of things. And while that might be true, that I think that really we should start to think of it, and I think we're starting to learn it's sometimes the other way, that pro-inflammatory or metabolic states then lead to obesity, and it's a chicken and egg dilemma. And I think the use of GLP-1 agonists, where people are now taking these drugs and losing weight, and they come off of the drug, their habits don't change, and they gain the weight right back. I think it does ask the chicken and egg question. Really, it's inflammation perhaps that leads to obesity, or the other, not the other way around. But I'd be curious your thoughts on that.
I think the whole GLP-1 thing is interesting. What the way I explain it to patients, because I screen everybody for prediabetes, insulin resistance, no matter what their weight is. And I would honestly say that I probably find prediabetes more commonly in my kids who are overweight to normal than I do in my like frankly obese patients. I think that has something to do with like maybe why those kids are being pushed into HS, but I don't really know. But I tell them, if we have high levels of insulin, not only is that pro-inflammatory and we don't know which way that direction is going, but it means that your body is fighting against you. If you are trying to do the right things, you are trying to eat right, you're trying to be active, your body isn't necessarily going to respond the way that it should if this is very high. So I do a good amount of metformin, same as Dawn. I start at 500 milligrams. I try to do the extended release. Most insurances will cover at least one of those brands that does extended release because it's better tolerated than the BID dosing if it's given with food. And then adolescent medicine typically expands that. I think it's worth finding somebody in adolescent medicine that you can partner with, or if you have somebody who's interested in your endocrinology group, like that's great. But like our endocrinologists, they won't see anybody if their hemoglobin A1C is less than 6 because they're just overwhelmed with people. So they aren't able to do that nutrition counseling for pre-diabetic patients. Like they can only handle the people who are really bad. So adolescent medicine has taken on a lot of that role. Same thing with PCOS patients. Endocrine is like, we see the really bad ones, but adolescent medicine manages most of those. So if you can partner with somebody at your institution, look at your adolescent medicine colleagues because they might be able to help you more than some of the specialists can for these kids who are not horrible with these comorbidities, but we need to address them.
So calling it sounds like that you might be starting the kids who, do they always have to have a A1C that's considered to be the prediabetes range? Or do you know, like if your insulin level is elevated,
So I do
you're
a HOMA IR score, which is not necessarily validated in kids, but if it's like way off, definitely gives me like, a reason. If their insulin level is over 20, or if their HOMA IR score, which is a relationship between your fasting insulin and your fasting glucose level, um, if that's really high, then I do offer most of those patients metformin. Now, not everybody wants it. Some people want to focus on lifestyle modifications. And sometimes that makes sense. Like if a kid comes in and I've had a kid who drinks, 3 64-ounce McDonald's sweet teas daily, then that's something that we can work on before we necessarily need to throw a medication at them. So, but I do offer metformin to anybody with an elevated fasting insulin level, or even if I can't get that fasting insulin level that day, if they have clinical signs, like if they acanthosis nigricans, like I'm still going to offer that to them.
And I know that we haven't talked on, nobody's asked this question, but I'm just going to put it out there. I personally think that directly smoking, vaping, or using marijuana or being exposed to those products in the home by secondary exposure, I think they all worsen HS. And as Chris was saying, these patients are depressed, they're anxious. Vaping is popular, marijuana is becoming legal. And more ubiquitous. And in my experience, the patients who are exposed to these by secondhand smoke or do them themselves tend to have more refractory disease. And so I really tried to get them into cessation programs and into psychology or psychiatry because oftentimes they're using those things for therapeutic reasons because of their mental health.
What do you guys think about like we have skinny HS patients. Like I have a couple of those. Do you find that they have the same, do you think it's more immunologic and they have less of this kind of insulin resistance phenomenon that we see? Or do you also see kind of resistance in these kind of skinny HS patients, but they might just like have more visceral adipose tissue or something like that?
I think of them as hyperinflammatory and hypermetabolic, kind of like other diseases where we associate it with high BMIs, but then the patients that are really sick actually tend to have cachexia. I think of it that way.
Yeah, same. I don't tend to find insulin resistance in the skinny kids, and they do tend to have some of the worst disease, and they tend to have some of the most difficult to control disease, anecdotally for sure.
Yeah, I mean, there are differences in phenotype that, probably have sort of different genetic and sort of other underpinnings to them. I mean, HS is a follicular disease. It's an inflammatory disease also, and sometimes it is much more probably driven by dysregulation of follicular maintenance, whereas other times it's much more driven by like inflammasome and bacterial response mechanisms. And so, those patients who have terrible ulcerations and pyodermal-like ulcerations and cribriform scar and sort of, that sort of what is often called like a syndromic form almost, like, yeah, that is very different and probably has different factors contributing than like the skinny little guy who's got like terrible, ice pick acne scars, which really aren't even like acne scars a lot of the times. It's like they just get this like follicular dissection that's almost spontaneous a lot of times. And if you look at a lot of these patients' cheeks, they have these can what look like tiny little ice pick scars everywhere, but it's really just like lots of dilated follicles. And they're like, I never really had any acne at all. It's just my skin did this over time. And those tend to be like again the skinny guys that have like really diffuse bad disease, lots of cysts and comedones everywhere. That's the population where smoking is most highly linked. Only like 20% of people in the US are smokers at this point, maybe even less than that. So like, people think we're seeing more and more HS. It's not clear if just detection's better or there's truly an increase in cases, but smoking, dove, a few fold over the last few decades, and we're still seeing tons of HS. But most of that smoking, again, is in like sort of the thinner patients with a lot of sort of, cyst and comedone formation. You don't see it as much in the patients who are sort of like, sort of the more overweight phenotype that's more frictional or there's a lot more frictional lesions and stuff like that. So, yeah, there's almost certainly some variations there. And the triggers and underlying genetics are probably different too.
Yeah, and it'd be really interesting to see, as someone who sees a lot of kids, many of them are vaping. And so it'd be interesting to see some of the differences between the smoking and vaping. But I mean, all these middle school kids and teenagers in high school are vaping. So yeah, but an important point to remember to counsel about. I'm also seeing, like we talked about, a lot more kiddos coming in on GLP-1s now. Is anyone prescribing them themselves? I haven't kind of ventured into that yet. A lot of times it's endocrine or some of the pediatricians doing it.
I always ask endocrine to do it. First of all, I don't think I'm an expert. Second of all, I think it's really important for insurance coverage that occur. It's sort of like today, for example, I had a patient who had EOE and had mild eczema. And so I asked the GI doctor to write the Dupixent prescription because I know that it'll pass muster with the EOE diagnosis versus the dermatitis diagnosis.
Same. I have adolescent medicine, or obesity medicine typically prescribe it, because mostly because of the insurance issue, but also because I don't feel like I know enough about it. And I feel like I'm trying to learn about so many other things for HS that if someone else knows how to do this, I want to let them do it. Our biologics coordinator is also basically at capacity. So like the idea of adding on another medicine that needs prior auths and fighting with insurance is a non-starter. But I think about GLP-1s in the same way that I think about biologics, which is that they work for some people and they don't work for other people. I have some kids who are on GLP-1s and it's just as good as a biologic. That is their only treatment and they are completely quiescent. Their scars have all calmed down. We're doing de-roofings just to get rid of the scar tissue, but they're doing great. And then I have some patients who are on GLP-1 and infliximab, and they're still terrible. And so I do feel like it still kind of depends on their phenotype.
Yeah, I'm like not I'm not really like very much on the GLP-1 bandwagon yet. Like I have a ton of patients, mostly adult patients who have been on them over time. Like 1 in 8 people in the US have been on a GLP-1 at this point, and like it was rare to hear like an anecdote of a patient in all those years who would come in and be like, "Hey, I just started Ozempic last month and I'm like doing way better all of a sudden," right? So like I feel like with the ex number of exposures I saw and the lack of like any real ability to connect those dots prior to all this sort of chatter about them in the last couple of years, like made me a little bit skeptical. And as I asked a lot of patients about them that happened to be on them, like I rarely heard somebody thought they were better. I've got one or two who feel like that after they started that things improved for them. Often we're doing other things at the same time for those patients, and so it's hard to tease apart like what's really helping them at that point. I'm somewhat convinced by that recent psoriatic arthritis paper because like I don't have another great reason why, like the group that was on dual therapy with ixekizumab and the GLP, and it was, I think, tirzepatide for that one, for the GLP-1, like why that group did a bit better, because I don't know that it's as linked to obesity with like with psoriatic arthritis. And so that's somewhat promising to me, but it was like incremental improvement. And like I have yet, I tell companies like I would much rather you like not try to do a GLP-1 trial on HS and develop me like a really good HS drug, like because I think I'm much more likely to see a response from infliximab or adalimumab even than putting a patient on a GLP-1 for the most part. And I need like really good HS drugs as opposed to some add-on or something that is going to be partly effective. And just like Colleen said, if they were like really, if they were sort of easy to get for people and cheap, like, yeah, maybe I would sort of put that burden on our clinic to sort of work on it and learn how to do all the dose titration prescribing because you have to write like 5 prescriptions just to titrate their dose up in the first 6 months. Like it'd be a huge pain. And I think we'd really struggle to get it approved most of the time. So like I just can't put that burden on like myself or the staff who like help with all these prior authorizations. So I'm not opposed to them. Like I don't think they make things worse and like they're overall good for patients' health if they need them for other reasons. And so if patients ask me about them, I say, sure, like it's possible it might help you some. Like I wouldn't hold off treating you with other things in hopes that a GLP-1 is going to help you over the next 6 months though. Like that is sort of a bonus. And if it helps, that's great. I'm not going to stand in the way, but I'm also not going to like push for something like that usually as a first step.
I agree with Chris and Colleen. I don't necessarily use it to treat the HS, but people get it coincidentally for other reasons. And one positive benefit of that is if they do end up losing a lot of weight, then they have a lot of skin redundancy and lost elasticity. And it's a good time if they were contemplating surgery or you thought that they needed surgical resection in various areas to consider that because it kind of takes care of the skin reduction from the weight loss at the same time that it helps with excision in specific areas that you were considering. And oftentimes that can be paid for more readily by insurance. You just have to be very mindful when you counsel the patients to talk about what they plan to do for the longer short term and the long term, meaning, do you plan on being on these drugs for a long time? Because if you don't, and to you, it's going to be a temporary measure to get you to a new set point, the data shows that most patients who come off the drugs, despite their best effort, end up gaining the weight back. And so the last thing you want to do is have a solid or significant skin reduction surgery to be helpful for the redundancy of the skin and the problematic HS areas, and then have them stop the medicines and then rapidly gain weight back and then have other skin problems that then get you back pretty much to square one, but with tighter skin and scars.
Just one final question here. For a lot of my PD patients, I might refer them and their families to the HS Foundation just to get some resources online. And, a couple of them come back and are like, oh, I've watched videos and like, wow, my disease isn't too bad, or vice versa or something, but it can have a really profound impact. Are there any other resources that you would plug for some of these patients or provide for families?
I'm going to put in a plug for HS Connect, who currently has an adolescent and a parent patient support group, like two separate patient support groups that meet monthly. You can go on their website and there's a link where you can just click and it'll sign you up. And I just recently asked, there's no lower age limit for the kids who participate in the adolescent group. She didn't think there were enough people to have like a preteen group, but I don't know, maybe some people could come up with enough people at this point. She said a lot of the stuff that they talk about is like there's colleges and relationships, but it's at a level that would still be like appropriate for younger kids. And I think having the parents to talk with each other is also a helpful thing too. There's usually a physician who's sort of in the background of those who can like address medical questions if they come up, but they typically don't, and it's just an opportunity for people to talk with other people who know what they're going through.
Awesome. So HS Connect. Okay, thank you. That's awesome. Dr. Syed or Dr. Davis, did you have any additional ones to add?
No, we have materials that we've written on mayoclinic.org and resources, but no other national supports. I like the HS Connect.
Yeah, awesome.
HS Connect is the most sort of biggest, most influential one right now. Like, and they have a teen group. They've also have like a male only group just because men would often like shy away from joining the groups that were mostly female. And so they have that. And then they've also, I think, recently decided to have, because of that, a female only group because they found, maybe that some women wanted a more female centered group that could talk about issues more related to, things that might be more concerns from a female standpoint. And so those are really good. And then, for the kids who are, old enough and mature enough for social media. Like, I mean, there are like influencers with HS on social media now. Like some of them, probably are, most of them have actually like embraced sort of like the other community of folks and people like HS Connect, like doing some education with them actually, where they like rounded up a bunch of the influencers who were sort of saying things that didn't always make sense and being like, hey, let's get you together and educate you. And so that you're putting out good information, and they kind of built a community that way. But I think from a social isolation standpoint, it can be helpful just to like see it normalized to some extent. Like it's one thing to like being in a support group is great and like and sort of gives you a bit of the community there. I think if a kid can like open up like an older teen can open up their Instagram and see like somebody talking about their HS and they're not afraid to like show off something that's under their arm, like that maybe even instead of putting it into a group like normalizes it to some extent. So if the kids are sort of old enough and mature enough, like pointing them in that direction like maybe is useful.
And I
Social
forgot
media
one other
is
one
tough.
that they're starting
Yeah.
with HS Connect. They're starting a parent group for kids with Down syndrome. So that's getting started up right now too.
Awesome. Thank you so much. Well, that brings us to time. Thank you so much to our expert panelists for joining us tonight and for sharing an hour of your time. Thank you to everyone that joined online on Zoom. We are so happy to have you here and for your great questions. Hope everyone has a great and safe evening, and we'll see you next time. Bye.
Thanks for having me.